Hello, everyone. In this session, we're gonna show some of the congenital heart disease, including TOF and the DORV. The first one here, you can see heart and the great vessel surrounded by bilateral lung. From the anterior side, you can see enlarged, very big ascending aorta here, and the aortic arch and branches of aortic arches. In contrast, usually pulmonary trunk is supposed to be anterior and the left side to ascending aorta. Here, we can see very small pulmonary trunk, left and anterior to ascending aorta. In normal heart, usually the size of the pulmonary trunk and the ascending aorta is similar, but here, pulmonary trunk is very small compared to ascending aorta. And ascending aorta is deviated to the rightward abnormally here. And aortic arch is the left side, so descending aorta is the left side. Okay, before going into the inside, let's see the right-sided atrium. Here you can recognize the triangle-shaped wide appendage portion, which is morphologically right-sided appendage here. And this is the superior vena cava, and here is the opening of the IVC. And let's see the other side. So when you look at the left side of the heart, then we can see very small morphologically left-sided appendage portion here, and pulmonary vein insert to the body of the left atrium. Okay, let's go into the inside. When we go into the right atrium, here we can see the fossa ovalis here. I think it's small opening here, but it's not as big as ASD. So still the foramen ovale is open. And then let's go into the right ventricle. So this part is the septal portion, and this is the free wall. And we can recognize very coarse trabeculation, which is characteristic of morphologically right ventricle here. So here is the tricuspid valve, septal leaflet here, and anterior and posterior leaflet around here. And pulmonary trunk, pulmonary outflow opening is here. And then between them, here is the ventricular septal defect here, which is, I think is a perimembranous type here. And then under the pulmonary valve, first let's see, pulmonary valve has, I think, only two cusps, so bicuspid pulmonary valve here. And then the diameter of the pulmonary valve is very small. And this, I guess this portion is a little bit detached, but this part has originally outlet septum, but this outlet septum is supposed to close this part, but this is deviated to anterior and superiorly, so this part is still open to make a ventricular septal defect, and this thick outlet septum part make the subpulmonary outflow tract portion narrow. And here, practically the subpulmonary outflow part is only this portion, which is very narrow. And also through the VSD, we can recognize, we can easily see aortic valve tissue here. So going into the overriding aorta. This heart shows the characteristic of TOF, which are overriding aorta, VSD, subpulmonary pulmonary stenosis, and right ventricular hypertrophy. So this is the TOF case before correction. I think this is before this. I think this one, yes. This is another case. When you look at the heart, it looks usually the normal heart is a kind of triangular shape, but this one is rather wide, especially right ventricular part shows a protruding area. So it looks like a potato instead of a triangle shape. This shape suggests right ventricular hypertrophy. In this case, we can see relatively sizable pulmonary trunk here, but the ascending aorta is rather big, and also is deviated to right compared to normal position. And this is the right atrium. Right atrium has a wide, big appendage and also prominent pectinate muscles. And here is the septal portion, septal part of the atrial septum shows fossa ovalis, and then tricuspid valve. And then let's go into the right ventricle. Yeah. So right ventricle shows the hypertrophy, very thick myocardial wall. But this one underwent previous operation. So the right subpulmonary outflow portion was already removed. So this part is still thick, but this part lost myocardial wall. And here you can see the VSD here, and also through VSD you can see the aortic valve easily, so indicating overriding aorta. And due to the previous operation of muscle removal, so we cannot recognize definite outlet septum, but previous outlet septum should have been here like this. So subpulmonic outflow, original one is only this portion, so which is very stenotic. And then in this case, this one also had operation. So let's see whether the pulmonary valve has 3 cuspid or bicuspid. I think this one has one cusp, and I think this is the dividing cusp. So this one also had a bicuspid pulmonary valve. But in contrast of the previous one, this one shows post-stenotic dilatation of the pulmonary trunk, I think. Yeah. So main pulmonary trunk itself is sizable, but the subpulmonic area had stenosis before. Then let's move to the cases after operation. More correction. Here you can recognize the potato shape, or is a bulbous shaped ventricle part of the heart, indicating right ventricular hypertrophy. And this one, overriding aorta here. And in this case, the aortic arch is right-sided. So usually it goes this way, but in this case, aortic arch go to the rightward and then posteriorly. This, so right-sided aortic arch. And from the anterior side, we can see some patch material at the pulmonary outlet portion. So it has, it was widened with the patch here, the substenotic, the stenotic pulmonary outlet portion, and so this is the tricuspid valve and septal surface of the right ventricle. And so this is the outlet portion, right ventricular outlet portion, and pulmonary trunk. So this one also has the pulmonary stenosis. So it's widened with the patchy. And I think it's originally, the VSD was closed by patchy as well, but this, at this moment is open again. And then we look at this one also shows the hypoplastic pulmonary trunk as well as a small pulmonary artery. So patchy was extended into the extended to up to main trunk, as well as some part of the bilateral pulmonary artery portion as well.
Professor Kim, can I interrupt you?
Yeah, sure.
So in this specimen, where is the coronal septum? How much developed coronal septum in these patients?
So this, at this moment, so the right ventricle is closed in this way, so we open like this. So I think this part is
because we
outlet
when you do
septum.
the TF repair, I
Yes.
think it's important for the development of the coronal septums.
Yes,
So
yeah.
I think in these patients there is a coronal septums are not well developed. So that means the aortic valve and pulmonary valve may be a doubly committed type VSD. Is it right? Well, how about Song Kim? Your opinion?
We consider the doubly committed. I would think the VSD should extend further into the anterior portion. Well, this part is it's not prominent, but I think this is the outlet septum.
Septum. Yeah, thank you.
And VSD is this portion, like this.
Yeah, thank you.
Yeah. Okay. This heart is rather very small. I think it's neonatal or like that. Okay. This also showed the prominent right ventricle part here. And this is ascending aorta. It's deviated to right-sided, like this. And here's aortic arch, and then aortic arch go to rightward and then posteriorly. So this is also right aortic arch. And then where is pulmonary trunk? Here, yes. And pulmonary trunk is small compared to ascending aorta, so small. And there is a kind of a continuity between pulmonary trunk and the ascending aorta. So here, I think this is, there is an opening between pulmonary trunk and the ascending aorta. So this aortopulmonary window is present. Instead of I think the ductus arteriosus between them, there is no connection, pulmonary trunk to aortic arch, maybe here. It might be very small, or anyway, there is no definite ductus here. Instead, there is a aortopulmonary window present here. And very big right atrium. And there is a foramen overlay. I think it is a rather big opening, so we can call it the atrial septal defect at this moment, like this. And when you go into the right ventricle, here is a septal surface, and this is the free surface, tricuspid valve. And here is the VSD, which is also perimembranous one, and it goes into the overriding aorta. And here we saw the pulmonary trunk here, and very prominent outlet septum present here. So very thin or almost obstruction of the pulmonary outflow tract part here. So this is also a TOF case, but unusually, which has associated with the aortopulmonary window. Okay, then let's move to DORV. This heart already underwent operation, so it has artificial conduit in front of the right ventricle. So I think this is the Rastelli operation specimen, and here this one, so we cannot see the original pulmonary trunk, but this one is the ascending aorta and aortic arch and descending aorta. We look at the right side of the heart. Then very big appendage, so morphologically right atrium. And this is the inside, so this is SVC and opening of the IVC. And here is some suture material, so maybe the atrial septal defect was present, but it was closed during operation. And then tricuspid valve, and go into the right ventricle. Then here we can see the patch with the suture material, which was covered by very thin endocardium. So this part is a previously ventricular septal defect here, which was closed by patch material here. From the right ventricle, we cannot find the pulmonary opening from here. Maybe somewhere here like this. So in this case, I can say this is pulmonary atresia. So in this case, in summary, I guess when before operation, here was a ventricular septal defect, and the ascending aorta was override through the ventricular septal defect and pulmonary atresia. So it can be called pulmonary atresia with VSD, TOF with pulmonary atresia, like that, and or we can describe it as doubly committed right ventricle with subaortic VSD and pulmonary atresia. Well, the name is described differently, but I think physiologically the same situation. So we can, this one was associated with pulmonary atresia, but this is a variation of DORV with subaortic VSD. In DORV cases, the position of VSD is important to understand the physiology of the situation. So when you have a subaortic VSD in DORV, then can be similar to TOF in case of the pulmonary stenosis or pulmonary atresia. This is another case of DORV. Here's okay, from the surface side anteriorly, we can recognize two main great vessels. This is the aortic arch part. So this should be ascending aorta here. And this is the pulmonary trunk. The size of two vessels are similar. And this ascending aorta is positioned where right-sided, where can be, it's not easy to judge it whether posterior or anterior. So rather right-sided ascending aorta. Okay, let's go into the inside. This is the right atrium. This is also has some suture material around the fossa ovalis. And let's go. Okay. This is the ascending aorta portion here. And this is a part of the right ventricle. And this is the pulmonary trunk here. And so this is the septal surface of the right ventricle. And here is the patch closing VSD to separate systemic circulation and pulmonary circulation here, like that. So in this case, VSD is VSD is still, it cannot be subpulmonary. So I would say this is the subaortic, but VSD is very big and how to say, so rather very, it's a kind of a segmented VSD, I think. So this was ventricular septal defect. The type of the VSD can be classified as a subaortic, but it's not typical. It's a kind of unusual. So we have seen the typical subaortic VSD and the DORV, and the unusual type of the wide VSD with the DORV. And this is the another type. Let's see. In this case, this moment, the ascending aorta and the aortic arch portion has silicone inside to have this portion is hard like this. And this is the pulmonary trunk portion, and the left and right pulmonary arteries. And here between them, there is the outlet septum. In this case, and that is rather definite here. When you look at inside of the right ventricle, so aorta is even deviated to the right side from the pulmonary trunk. And this is the septal surface and free surface of the right ventricle. And where is the VSD? In this case, VSD is present beneath the pulmonary trunk. Yes. Here. The first one, Dorv case has the subaortic VSD, but in this case, that is the subpulmonary. So the physiology of this DORV is like TJ. In contrast to the subaortic VSD like TOF. So in this case, the blood flow from the left ventricle go into the VSD and then go to the pulmonary trunk instead of the ascending aorta. That was the in this situation is called Towsing being anomaly, which has the physiology of TGA. And so this was the DORV with the subpulmonary VSD. But this one was closed by suture, so we cannot see inside, but anyhow we can see the great vessel morphology from this case. Here, so here is the aortic arch around here, so we can recognize as ascending aorta here. This is the pulmonary trunk, and the pulmonary artery arises from this portion like this. And this, so ascending aorta is positioned right side and rather anteriorly to pulmonary trunk. So it's, the position is like a TGA situation. We cannot open, I think it's closed, so we cannot see inside. I think Dr. Seo wants to make a kind of a siliconization of the inside of this heart to see the relationship between two great vessels. So this one, I assume the VSD was present below the, beneath from the pulmonary trunk, far from the ascending aorta. This position, aorta is deviated to the right side further, so septum should be somewhere here. So VS would present somewhere this part like this. Let's see what kind of anomaly this heart has. This one has a very prominent ascending aorta here. Yeah. And rather small, very thin walled main pulmonary trunk. So it has, I think, a pulmonary stenosis here. And the ascending aorta is positioned so right and anteriorly like this. Let's see inside. So this is the inside of the right ventricle, septal surface, and free wall. And this is the aortic valve here, and we can see the coronary opening here. So this is a definitely aortic opening. And so this is a kind of a ventricular septal defect. but where is the opening of the pulmonary trunk? Here's the pulmonary trunk here. But from the inside, and maybe here. 이쪽으로는 없기 때문에. There is no direct opening from the left ventricle here, only ventricular septal defect. So the opening, the connection of the pulmonary trunk is supposed to be from the right ventricle. So I think from this area, but I'm not sure. This is, okay, let's see from the up. So I think it is pulmonary trunk is present, but the pulmonary valve level, there was no opening here. So it's also pulmonary atresia. And unusually also the ventricular septal defect is not either subaortic nor the subpulmonary. Is distant type, non-committed ventricular septal defect type in this case. And ventricular outlet is ascending aorta is connected from the right ventricle with definite opening. Even though there was no opening toward the pulmonary trunk, but I think it's a kind of a remnant of the pulmonary valve present connecting to right ventricle. So this is DORV with the pulmonary atresia and non-committed ventricular septal defect, which is also relatively rare type of the DORV.
So, this heart has far from aortic valve. So, do you think is it possible to the positive baffling from LV to aorta in this specimen? In this case, pulmonary opening is closed. So anyway, the VSD is deep-seated under the tracheal valve, right?
Yeah. Yes.
So it's very difficult to tunneling, baffling from LV to aorta.
I think this VSD is very far from aortic opening here. So if we want to make a kind of baffling, it should be very long, and tricuspid valve present here.
So if it's not possible to with baffling, we can do the Fontaine operation in this patient. But I think you can try to the baffling.
This way. Yeah.
What kind of try?
Yeah.
What's your option?
So
you can try the baffling.
Try the VSD baffling.
And then the pulmonary flow from the right ventricle.
Extracardiac conduit. Place the extracardiac conduit, RBPA conduit.
RBPA. Is there any space for that patients after baffling?
Yeah, in these patients, VSD is deep-seated, and VSD baffling from deep-seated original VSD to the aorta, and we make anterior hole for the conduit.
Can you see the specimen? Yeah. Is there, if you, where can you incision on the right ventricle for the conduit?
Yeah, maybe, you can explain, self, it'd be much easier.
Maybe here?
Here?
Yeah, here, maybe make a hole here and connect this conduit here.
But I think that after the VSD baffling, because it's an inlet VSD, the RV cavity is very small. So I think even though you made a conduit, RV volume is not so good.
Yeah, right.
If the pulmonary annulus size is a little bit bigger, you can make a translocation and then.
Actually, in this patient, there is no space for translocation because the pulmonary atresia, muscular atresia. Yeah, so it's very difficult to do.
So previously, we usually perform the Fontan track in this kind of patient.
Right, yeah.
The biventricular repair is very difficult.
Difficult, right, yeah.
Okay, from the anterior, we can recognize ascending aorta here, and I think this is the pulmonary trunk here. Aorta is positioned right side, but I think rather posteriorly. So I assume we can see a subaortic VSD inside, like that. This heart underwent operation previously, so it's not easy to see the original position. But anyhow, this is I think it's a patchy to close to VSD to connect from left ventricle to aorta. Right? Yes. Yeah. Aorta is here. And this one is very big. See? And pulmonary trunk originates from the right ventricle and here, like this. But I guess the subpulmonic portion is narrow because this patch make the way from left ventricle to ascending aorta. So subpulmonic outflow portion is small. So the surgeon used patchy to make the pulmonary outflow portion widen and this way. Yeah, this is the patchy to widen the outflow part of the pulmonary trunk area. The trunk itself is relatively big, even a little bit dilated from, I guess, because of the flow from the right ventricle area. And so DRV cases, the aorta is deviated to the right side. So this patchy part is rather very wide to make make a kind of a tunnel from left ventricle to right deviated ascending aorta. Okay. I think we have seen main specimens.